here was a randomized double-blind placebo-controlled feasibility study looking at the possible role of Chinese herbal medicine in treatment of recurrent urinary tract infections, which was done by Andrew Flower in our department in Southampton. Andrew is a practitioner of traditional Chinese medicine. And I know this isn't Ayurveda, but I think I'm raising it because I think similar issues would apply. So the objectives were to assess a feasibility of delivering Chinese herbal medicine in UK primary care, safety, and getting some exploratory estimates of effect size on reducing frequency and severity of infection. Why recurrent urinary tract infections? Well, it's a difficult problem. A lot of these patients end up being on long-term prophylactic antibiotics. Obviously, we have a problem with increasing antibiotic resistance. So this is an area where it's key to find an alternative. Obviously, we wanted to look at the impact on antibiotic use. So this was a feasibility trial, but I think it's quite interesting. So it aimed to compare two different things. It aimed to compare standardized active herbs versus a standardized placebo and delivered by a GP, and individualized active herbs versus an individualized placebo administered by practitioners of Chinese herbal medicine. And the aims were to explore the difference between the active and placebo herbs, so the specific effect, the differences between standardized and individualized herbs, and a comparison between the contextual effects of Chinese herbal medicine via a GP consultation versus a traditional Chinese medicine consultation. So they managed to recruit 31 women in each arm. The standardized arm, they found it much harder to recruit. They recruited via GPs in health centers, and over half of the patients actually withdrew or were lost to follow-up. And Andrew felt this was because the GP's heart wasn't really in it. They weren't quite so, enthusiastic about the herbal medicine side. Whereas the individualized arm, the patients were self-referring to the practitioners, so the rates of dropout were much lower. Unfortunately, there was a technical issue in that the company supplying the individualized placebo didn't understand what a placebo actually was, and they actually gave the placebo group some active herbs, which sort of undermined the scientific basis of the trial. But anyway, that was by the by. So in the individualized group, there were good improvements in all the outcomes that were measured: urinary symptoms, frequency of infections, severity of infections. And in terms of use of antibiotics, in the light green is the individualized arm. You can see they appeared to do slightly better. So a lot of people completely stopped or decreased how many antibiotics they were taking. So this was all very promising. But the problem is, how do we take this forward? And it hasn't been taken forward. And for various reasons, I think Andrew got so frustrated with the whole research process that he's actually completely abandoned research and just gone back to working as a practitioner. I mean, the problem is it's much easier to scale up standardized treatment, but it was less successful in this example. And I'm sure the same is probably true for Ayurveda. Individualized treatment appears to be better, but it's more difficult to evaluate it and to scale it up. And the question is always going to be, how generalizable are these results? Okay, we can see that this group of practitioners following these guidelines had good results, but how do we know that that would apply to other practitioners? In the course of my training, I observed various Western herbal practitioners, and I can say that in my opinion, the quality of what they did was extremely variable. There were a few who I thought are excellent, and if I ever had something, I would go to see them. There were quite a few that were fairly average, and there were some that are fairly mediocre. I thought I'd never touch them with a barge pole. So I think there are, the quality of the practitioner is variable, and that's a challenge. Could we imagine traditional herbal practitioners working alongside conventional doctors in the NHS? Possibly. Michael Dixon has tried that model. But it hasn't caught on very widely. And I think part of the problem is there may not be enough practitioners. If we wanted to scale it up throughout the whole of the UK, there may not be. And then there are questions of cost effectiveness, because of course people's time is expensive. So it's a challenging issue. And I don't think I have the answer to it, but I'd be interested in your thoughts. So the second challenge I wanted to raise is the issue of the need for GMP products for doing clinical trials in the UK. The example I want to give here is an Ayurvedic herb, Andrographis paniculata. So this was a systematic review done by some of my colleagues in Southampton on Andrographis for symptomatic relief of acute respiratory tract infections, which gave very promising results. So a very statistically significant reduction in the time of the illness, time to symptom resolution by 3.5 days. That's much better than you get with antibiotics. That's compared to usual care, and compared to, if you add it to usual care, it still gives you an improvement of 1.2 days. So really promising results. And this is a sort of forest plot for those who like these things. You can see that the summary diamonds for cough, sore throat, overall symptoms, they're all statistically significant. So we had a PhD student who was funded by Pucker Herbs, who did a feasibility trial, which they called Gruffalo, standing for Andrographis paniculata. So slight stretch on the acronym, but anyway, it was, I suppose, designed to appeal to British patients with the association of the acronym. Anyway, so they got 2 groups of 30 patients. They randomized to capsules of Andrographis versus a placebo, and were looking at feasibility of recruitment and so on. There was also a qualitative bit where they interviewed GPs on their views on herbal medicine. And the results were really positive. About 1/3 of the screen patients were recruited, 81% were followed up. Adherence was a bit of a problem, and I think this is a recurrent issue for some of these herbal medicine trials where you've got large numbers of capsules that you have to take. 12 capsules is quite a lot for some people. Anyway, we were able to collect data. Antibiotic use was low in both groups. There were few side effects, and the conclusion was we need a full-scale clinical trial. But the challenge is, what is the best formulation? And the problem is that the UK regulations for clinical trials, for a feasibility trial, it's quite easy to get regulatory approval. Your aim is showing feasibility of recruitment and follow-up. The efficacy is not a primary outcome. You can say there's a signal of effect, but you can't claim that it's effective from a feasibility trial. But for a full-scale randomized trial, you need a clinical trial authorization, a CTIMP license, and you need for that a product manufactured by GMP. And therein lies the problem, because we really wanted to do a full-scale trial of Andrographis, but, sorry, I don't know what's happened there. It's jumped to the wrong place. We need to go back. Sorry. More? Yeah, more.
Can you remind us what GMP
yes.
is?
Good manufacturing practice.
Thank you.
So it's made in a factory that has to be certified according to all sorts of different standards. And the problem is there's no GMP preparation of Andrographis available in the UK. So we can't do this trial that we would like to do. Pucker Herbs that used to produce Andrographis capsules, it wasn't GMP, and they've stopped producing it now because they've been taken over by another company and they're focusing just on the teas. They're not making herbal capsules anymore. Other manufacturers, we haven't found any. There's a company called MediHerb in Australia that imports a preparation, but it's only available by practitioners, and it's very expensive. I think it's like £40 for a course of treatment, which is well beyond what most patients would probably be willing to pay. I've heard there are GMP manufacturers in India, in China, but we haven't managed to secure it yet. And this, by the way, isn't only a problem in the UK. I was approached by somebody in Switzerland who also wanted to do a trial of Andrographis, and they couldn't get hold of a GMP preparation. So they did it on a different herb in the end, so which is a real shame, because Andrographis is really promising. It's an example, I think, of something that could be adopted if we could only get the preparation needed. Oops. Okay, so this is an example of a herb that does have a GMP preparation called Pelargonium. It's not an Ayurvedic herb. This is a South African herb, but it's available over the counter in Europe, also for the treatment of respiratory infections. And the problem I want to highlight with this example is the issue of obtaining funding for research. So once you've got the GMP product, that's not the end of the story. So Pelargonium, we got interested in. There's a systematic review, a Cochrane review, There are 3 trials of efficacy for acute bronchitis in adults, 2 in children, showing the liquid preparation was quite effective. The tablets were not. There were also 2 trials of efficacy in acute sinusitis, which again, seems to show the same thing. So it's quite promising preliminary research, but the trials are quite small. And the recommendations on it, it's actually made it into the NICE guidelines on self-care for acute cough, although it's a very weak statement. It says, be aware that some people may wish to try the following self-care treatments, which have limited evidence of some benefit for the relief of cough symptoms. And they mention pelargonium, but pelargonium is the only herbal medicine mentioned in that NICE guideline. So it's better, it's a start. But we would like there to be a stronger recommendation in there saying there's quite good evidence that this works and you should recommend it for your patients. So in order to get there, we need to do a better, bigger randomized controlled trial. So we got funding for another feasibility trial, which we called HATRIC, Herbal Alternative Treatment for Lower Respiratory Tract Infections with Cough in Adults. And this was the sort of plan. We would randomize adults coming to their GP with an acute cough, less than 21 days, randomize them to tablet, or the GP practices were randomized to either giving tablets or liquid, so we weren't sure which one was going to be better, and the participants within each practice were randomized to active or placebo. And they were told to take it 3 times a day. GPs were allowed to give antibiotics alongside it if they felt it was needed, immediate, delayed, or no antibiotics. And then we followed patients up for 28 days. So this trial was quite successful. Sorry, that's probably too small to read, but basically we managed to follow up 80% of participants. And the study wasn't powered to detect a difference in efficacy. It was a feasibility trial, but nevertheless, there appeared to be a signal, at least that the liquid group on the 3rd row down, if you look, 30% had all their symptoms resolved by day 7, 32%, which is a bit better than the placebo. So it looks, and the moderately bad symptoms were resolved in over 50%. So it's looking promising. It's not statistically significant. So we want to do a bigger trial of it. Qualitative results, people were positive about the trial process. The majority of people wanted to try alternatives to antibiotics. The majority of patients were positive about herbal medicine. They preferred the tablets. Interestingly, they found them easy to take. They found it difficult to take the liquid. It was more complicated. So by and large, good feedback from the patients and from the doctors involved. So it's feasible to recruit and retain participants in a randomized trial of herbal medicine in UK primary care. There's a challenge in that we're not sure which formulation we should use. The Cochrane review suggests the liquid is better. The patients prefer the tablets because they're easier to take. They can carry them in their pocket to work. And we had a bit of a debate about what should be our primary outcome. Should it be improvement in symptoms or reduction in antibiotic consumption? Obviously, patients are more interested in the first. Public health people are more interested in the second. What if you have to pay for it? It's quite clear the NHS probably wouldn't pay for this. So, well, the cost is similar to a prescription. But obviously patients who get free prescriptions and, who are really hard up may not, be able to afford that or want to pay for it. So we wrote a proposal to the NIHR for a full-scale definitive trial of pelargonium versus placebo. We spent quite a long time writing it. We delayed actually submitting it because of COVID. We had to wait for a couple of years because we thought this isn't going to work during COVID. We submitted it earlier this year, and this was the response we got. I'm sorry to inform you, we will not be considering your application any further. This was out of remit due to lack of published evidence in peer-reviewed journals. There's a Cochrane review, for God's sake, and there's our feasibility trial. Lack of evidence in peer-reviewed journals for efficacy of the intervention to support the clinical trial proposed. I mean, I spoke to my colleagues about it, and my senior colleague who ran the HATRIC trial said, I wish they'd just be honest and say they don't want to fund herbal medicine research, because that's not a real reason. So that brings me on to the next issue, which is, are people on funding boards and even on guideline panels, are they making their decisions based on evidence or based on prejudice? And for this, I want to give you an example of St. John's wort, which is not an Ayurvedic medicine, it's a Western herbal medicine. But I think it illustrates the point. There's a Cochrane review that was published in 2008. It has 29 RCTs in major depression. including almost 5,500 patients. And the results are very conclusive. The side effects are fewer. There are fewer patients who discontinue St. John's wort than standard treatment due to adverse effects. Sorry, the print is a bit small, but the diamond at the bottom to the left of the line means that there's a reduced, yeah, there we go. There's a reduced rate of dropout and side effects. So effectiveness, it's clearly more effective than placebo, 2.77 times more effective than placebo. Oh, sorry, I need to get the cursor back in the right place.
There it is.
The cursor's gone. Oh, there we go. Okay. And if you compare it to standard antidepressants, the older antidepressants, tricyclics, there's absolutely no difference. It's equally effective. It's equally effective to the more modern antidepressants, the SSRIs. So efficacy is the same as standard antidepressants. So now what do the NICE guidelines say about it? They actually say you should not recommend St. John's wort to patients. And the reason they say that is, number one, there's a risk of interactions, which is true. It interacts with a lot of modern medicines. It activates the cytochrome P450 system in the liver, and it speeds up your metabolism of the oral contraceptive, methadone, antiretrovirals, a wide range of drugs. But interactions is part of our job. Every medicine has interactions. The back of the BNF has a long list of interactions. That's what doctors do. They decide what you prescribe according to the interactions. So that's not a valid reason. And that second reason they gave was variability in the quality of preparations. Well, if it was recommended as something you could prescribe and the quality was controlled, that's an easy problem to solve as well. So these are not valid reasons, but that's why the NICE committee says that St. John's wort is not included. In fact, it's more than not included. That's wrong. It is included, and it says, do not recommend St. John's wort. So it's actually worse than not included. It's actually telling people not to use it. I went to a very interesting talk in Oxford about 10 years ago now by a psychiatrist who had done a network meta-analysis of antidepressants. And I asked him afterwards, why was St. John's wort not included? And he told me, off the record, this is off the record, he said, it was included, but it came out best, and we couldn't have published that. It would have ruined our reputation, so they decided to leave it out. So to me, that is not evidence-based medicine. That's prejudice-based medicine. Okay, having got over the challenges, I then wanted to sort of finish with maybe some opportunities. So I think there are opportunities, some of which were mentioned yesterday, which I'm not going to repeat, but I wanted to add these ones. The NHS and NIHR's top priority include tackling inequalities and ethnic disparities in health outcomes, equality, diversity and inclusion, and patient and public involvement. And I think all of these are important opportunities that we should try to use for research and integration of Ayurveda. So health inequalities are widening. This is a graph on life expectancy according to the age at which you're diagnosed with type 2 diabetes in high-income countries. And I'm sorry, the print is a little bit small, but basically the younger you are when you're diagnosed with type 2 diabetes, the greater the number of years of life lost. So if you're diagnosed I can't even read that myself, under the age of 30 is the blue line, on average, you're going to lose 16 years of life, as opposed to if you're diagnosed much later in life. So, and more people are being diagnosed now with diabetes earlier in life. And diabetes is a particularly good example for this, because if you look at the percentage of people who have diabetes in the UK, the prevalence is far higher in patients whose ethnic origin is in the Indian subcontinent and Africa. Much higher rates of diabetes. And not only the rates are higher, but also the percentage of patients with poorly controlled diabetes are higher. So this was a study from Scotland. I mean, it's not great in the white Scottish. It's 47% have poorly controlled diabetes, but patients of Indian origin, 59%, Pakistani origin, 66% have poorly controlled diabetes. So really, we're not doing very well for anybody. And of course, these inequalities lead to worse outcomes, greater morbidity, greater mortality, which is greater in patients from different ethnic minorities in the UK. Adherence to conventional treatment, we know, is not very good, and fewer than half of patients take their medicines as prescribed. A major reason for that is side effects, and it leads to worse control of diabetes, more complications, more costs for the NHS. So we know, and I'm sure it's been already mentioned, a lot of people use herbal medicines for diabetes. Globally, over half of people with type 2 diabetes are using some form of complementary medicine. In the UK, there was a study showing that 2/3 of the Pakistani community prefer to use natural remedies. And yet the NHS provides no information to patients about natural remedies and which could be effective. And most patients don't even tell their GP about the herbal medicines they're taking. Yeah, so we did an umbrella review, which was a review of other systematic reviews of herbal medicines for controlling blood glucose in type 2 diabetes. We were only looking at systematic reviews that had already been published. We found 34 of them. So by the way, doctors who say there's no evidence on herbal medicine, they're out of date. That's what we were taught 30 years ago in medical school. It's not true anymore. There's a lot of evidence. And this was our sort of league table, which I thought was quite interesting, the effect of different medicinal plants on HbA1c, which is a sort of measure of how well your diabetes is controlled. So the red dotted line is a reduction in 0.5% of your HbA1c, which is roughly what you would get with metformin, which is the standard treatment. So any dots to the left of the red dotted line are actually better than metformin. The white black line means there's no effect at all. That's a zero change. So if you're to the right of the black line or on the black line, that means it's not effective. So the top plants, aloe vera came as a surprise to me, but that was the one with the biggest effect. Not far behind it was fenugreek, which is obviously an Ayurvedic medicine. Plus there was ordinary nettle, a Chinese remedy, and Nigella sativa, the black seed. And interestingly, at the bottom, cinnamon came out as not being very effective, which I thought was interesting, but there were 4 systematic reviews all coming to the same conclusion about cinnamon, that it doesn't really have much effect. So I think this information is quite important, that patients could be better informed about which herbal medicines they want to choose for their diabetes. So fenugreek, I'm sure you all know and love. It's a very commonly used food. It's generally regarded as safe. There are several mechanisms by which it reduces blood sugar, it delays gastric emptying, it interferes with glucose absorption, and it has a compound that stimulates release of insulin. It comes in various preparations, so we perhaps need a bit more information on which preparation is best and how to use it. With some of my colleagues in Southampton, we've updated the systematic review on fenugreek because the one we included in our umbrella review was had various methodological problems. It was a bit out of date. So we found a similar thing, essentially, that it reduces HbA1c by 0.82%, which is better than metformin. Of course, there are other herbs that weren't included in the review, like gurma, which hasn't had a proper systematic review. And yet I'm sure that anyone who's tried it is quite convinced of its effectiveness. You just have to taste it and then to be convinced. Okay, so I worked in a practice in East Oxford, which is a very multi-ethnic area, about 40 different ethnic groups. We held a patient and public involvement group to get patients from feedback from patients on, because we had noticed a lot of our patients, especially those from various ethnic minorities, had quite poor control of their diabetes and were not really engaging with the standard treatments and standard lifestyle advice. So people gave feedback like frustration that they'd just been referred to a dietitian. They had to wait a long time for the appointments. They were getting information from YouTube, which isn't necessarily very reliable. Most people agreed they needed support with their diets, and they liked to have information on dosages and practical measurements of different glucose-lowering foods and spices. So people want to know about this. We also did a review of qualitative studies on what people think about using herbs for type 2 diabetes from all over the world, not just the UK. And what we found is that people are practicing double-blind medicine, and I don't mean double-blind randomized controlled trials. I mean patients don't tell their doctors what they're doing, and doctors don't ask the patients what they're doing. So this patient from Jamaica says, I'm not discussing any herbs with the doctor, because when you tell him about herbs, he says, nonsense, foolishness. So I continue to drink the herb. I put the medicine aside for a while, go on the herb, and then back on the medication. And then this is a GP from Ethiopia. If I ask the patient whether he or she has been using herbal medicine and found that he or she was using any herb, I wouldn't take any decision towards using herbs because I don't have any knowledge about the specific herb and the conventional anti-diabetic drug interactions. So a lot of patients with diabetes are seeking a cure, and how they do that involves various things. Could be to do with religious or spiritual beliefs. It could be advice from the family or their community, traditional healers, the media. It could just be trial and error of different things. But what it's not is talking to health professionals. They're very reluctant to talk to health professionals about the herbal medicines because they know or they think that they're going to get a not very helpful answer. So, oops, can I go to the next?
Sorry, yeah.
Yeah.
Try
that. Yeah, okay. So both doctors and patients want evidence-based advice on herbal medicines to guide their decision-making. And this was an idea that was put together by one of my colleagues in Switzerland, was to have a little booklet, an information booklet, or could be a website for patients about not so much telling people what not to eat, but saying what you could eat, what you should try and incorporate into your diet, which might have a good effect on your diabetes. And the idea was that people could be given a choice from this different list, choose what they want to add into their diet. And there's this is a draft of providing evidence-based information on what preparation, how to take it, possibly precautions and adverse effects, and some ideas of recipes that you can include it in. And we're moving towards the idea that actually it might be easier to do a trial of an advice intervention, like a trial of giving a booklet to people rather than a trial of a specific medications, because it gets around all the regulatory issues with needing to have a GMP product. It's pragmatic, real-world evidence. The disadvantage, of course, is you can't control the quality of what people go and buy. And we know there's quite a variety of different products on the market. They might go and buy something that's not very good. And this sort of evidence may not be accepted by official bodies like NICE for making recommendations. So that's the disadvantage. Although, as we've seen, even conventional good trials are not necessarily accepted either. So, yeah. So I've got a PhD student at the moment from Uganda who's working on improving self-management of type 2 diabetes in patients of African heritage in the UK. There's no reason why we couldn't do this, looking at patients of Asian heritage. She's doing a systematic review, qualitative interviews, and then designing and piloting an advice intervention using the patient-based approach. And we hope it'll lead to better understanding of support needed by type 2 diabetes patients from ethnic minorities in the UK, with some culturally appropriate evidence-based advice on diet and natural herbal remedies. You know, when people come to us for weight loss advice, they get referred to Weight Watchers or Slimming World, which just tells them about a standard British diet. It doesn't give you appropriate advice about, an Asian diet or an African diet. And I think people will feel more motivated to engage with self-management of diabetes if, as a medical profession, if we show interest in their herbal medicines. I had a number of patients coming to me in East Oxford saying, what do you think of this herb or that herb? And I was trying to be quite supportive, but a lot of doctors will just completely dismiss it. And so ultimately, I think hopefully this should lead to better glycemic control, improved diabetic outcomes, especially for those at highest risk. So in conclusion, could Ayurveda be integrated into the NHS? I think possibly, but there's a number of conditions. We have to agree on appropriate situations for standardized, where standardized preparations could be used versus when do we need individualized. We need to have better collaboration between the NHS and practitioners for those cases that do need individualized treatment. There need to be high quality preparations of effective herbal medicines that can be easily available and affordable, both for the trials, but also for doctors to be able to recommend to their patients. And as I've demonstrated, at least in the case of Andrew Grappis, that's not the case at the moment. You can't easily get it in the UK. There isn't a preparation we could put into a trial that's readily available. The guideline committees and funding boards need to be more evidence-based and not prejudice-based. And that's a difficult nut to crack, but hopefully that will start to change with time. And I think key to all of this is more involvement and engagement of patients of South Asian heritage, because I think if the patients are asking for it, then the NHS and the NIHR will have to listen. So thank you very much, and I'd be happy to attempt to answer any questions.